60 years ago, a medical miracle occurred that allowed me to be here with you on this stage today. When my mom was 3 years old, she was diagnosed with VSD, ventricular septal defect. She was a sick little girl. The doctors told my grandparents that she had to wait to have surgery until she was about 10 years old, and then the chance of survival was 50%. So they waited, and they prayed, and they worried for 7 years that their child would have the procedure that she so desperately needed. She had a procedure at Presbyterian St. Luke's Medical Center, which is now Rush in Chicago. The surgery was rough, and the recovery back then, it was really long. She spent 3 weeks in the hospital, 10 days in ICU. For 21 days, my grandmother held my mom's hand, wanting everything to just be okay. My mom has since gone on to live a great life. She has 3 grown kids, 5 grandkids, a great marriage, and a super social life. Thanks to the ongoing commitment of the healthcare support system and the work of and marvels of modern medicine, we can focus on improvement. And kids who need this surgery today have better outcomes many times, as you know, in an outpatient surgical setting. So I have the opportunity to give talks like this pretty often. And each time I do that, I want to make sure that my comments resonate with the audience. So I do my homework. I've spent time speaking with the staff at ACC and also having conversations with the faculty and chairs of the program. I want to get things just right. And then my mom sent me an email right about the time I was preparing for this, and she said Aunt Marcia had reached out. My Aunt Marcia works on the ACC registry at OSF St. Joseph Hospital in Bloomington Normal. And she received an email, a promotion for this event that I would be speaking here with you today. So, as part of my due diligence, I called Aunt Marcia. I ran my talk by her, I shared with her my thoughts, and she gave me some ideas about how to just perfectly thread that needle for you. So I want to send a shout out to Aunt Marcia and thank her, and I think some of her team members are here in the audience today. So the program chairs and Aunt Marcia, they confirmed for me that this conference is all about quality, all about improvement, and the thing that you care about the very most is improving patient outcomes. My talk is about improvement too, but it's about a different type of improvement. It's about improvement of the discipline of quality and safety via the workforce of all of us and each of you. We talk about improving healthcare delivery all the time, as we should. And I know that people who work on registries are very, very committed to that. Some might call you obsessed, a little bit, right? But I totally get it, I get you. And so for the next hour, I'm gonna ask you to think about improvement just a little bit differently so that you can understand and maybe further contemplate your own role and how to maximize your human potential. Because at NACU, the Q is you. I'm from Bloomington Normal, Illinois, where I grew up around Aunt Marcia. And I have to tell you that I had no idea that I was going to work in healthcare or that I would go on to run a nonprofit, mission-driven healthcare organization. The closest I got to healthcare as a small child was hearing stories from Aunt Marcia about what was going on in the emergency department that she worked in at the time. So, long story short, I was 24 years old in 2002, recently married, and out of a job. I found employment at the American Orthopedic Association. This organization was focused on academics, and it supported department chairs and program directors for residency programs. There, I had the opportunity to learn about academic pathways, and I became very interested in how physicians were trained to do their work. I learned about the academic pathway of medical school, residency, and fellowship. I also had the opportunity to participate in my first quality improvement project called Own the Bone. My boss said to me, "Congratulations, you've been chosen to run a $350,000 grant-funded nationwide quality improvement project to reduce secondary fragility fractures." My response was, "What's a fragility fracture? And what's an improvement project?" I went on to lead that improvement project and even publish with some of the brightest minds in orthopedics. The biggest industry leaders from NYU, Dartmouth, Emory, and many more participated in a successful program. And it was at that time that the quality bug bit me. In 2006, I was offered the opportunity to work at the American Academy of Physical Medicine and Rehabilitation. I went there to expand my scope of work. So this organization was less about academic pathways and more about supporting physicians in practice. It was there I was asked to lead the education department. I learned about maintenance of certification, board certification, research, and how that all was designed to impact and improve healthcare delivery. And I started asking questions like, where is the practicing curriculum for physicians? They need to know things different than when they were trained in medical school and residency and fellowship, right? A few professions, like ophthalmology, were really ahead of the game. And they had already developed practicing curriculums for their professions. And I convinced my board that we should too. So we defined the practice-related competencies for PM&R physicians in a postgraduate environment. And today, that resource is the practicing curriculum for PM&R docs, and it is a point-of-care resource for them to use in practice. So I went on to work at NACU in 2013, and when I interviewed for the job, by the way, I was pregnant. 7 months pregnant, in fact. And just a quick sidebar, that experience of being 7 months pregnant, interviewing, by the way, it was really hard to find an outfit twice to interview with. But that story and the story of NACU's journey and how we are unleashing human potential was recently featured in a book that I had the opportunity to author a chapter in called Unstoppable. And this book is all about advancing women leaders, and all of the proceeds do go to advancing women leaders. So I want to tell you about that because that's a really great story, and you're going to get a sneak peek into that today. So as I took the job at NACU, one of my main objectives was to really understand more about the back of the house of healthcare. I had worked with physicians in orthopedics and PM&R and had a pretty good grip on what went on in the front of the house of healthcare. But to put that together with what went on in the back of the house, where a lot of you work, was really exciting for me. I also did it because I believed that quality was the future of healthcare and would provide the answer to many of the challenges that we experience today. So, new on the scene in 2013, I started a self-directed orientation. And the first question I asked the board of directors was, where's the body of knowledge? Where are the procedures, the standards, the curriculum for this profession, for this discipline? I need to learn about it. They told me, well, you should look at this textbook. Someone said, you should look at that textbook. And others said, well, the body of knowledge is the CPHQ. So how many of you are CPHQ out there today? Yep, me too. Great, good representation. We now have more than 15,000 CPHQs today, and it's an outstanding certification. But it isn't a body of knowledge. So my question to the board at that time was, how are we going to advance a profession and a discipline without a body of knowledge? So what started as question asking soon became pencil sharpening. And we created a solution. But first, I want to tell you more about the question asking part. So I drew on my experiences from the American Orthopedic Association and the American Academy of Physical Medicine and Rehabilitation that taught me about the bodies of knowledge. I learned that in absence of an academic pathway for quality, that quality had been built on the fly at a local level without the benefit of a standard. And that each time there was a new rule or regulation or new ambition for quality, a new person, a new role, or a new layer would be added to the infrastructure to support it. As a result, what we have is homegrown systems, processes, structures, and even a homegrown workforce, where the dominant strategy has been on-the-job training. So I asked myself another question. Why are all these skills so variable? Most people working in quality come from nursing, are physicians, or have some other clinical background. Why are they not all learning this in their clinical practice setting? What I learned is that each of them are trained differently based on the profession that they grew up in. Or sometimes they weren't trained at all. So my big aha here was that most people who come into quality were really good at something else first. How many of you have been formally trained in quality and safety? Higher ed programs, structured multi-month year boot camps of any sort? Yeah, not very many. This is a second profession, and that does not come with an academic pathway. So what happens when all of us show up to work from different professions and from different training programs? Well, what happens is some know what a PDSA is, some don't. Some know what an RCA is, some don't. Some know how to collect and analyze data and tell stories with that data, some don't. Some know what a culture of safety is, and some simply don't. Different vocabularies, different toolkits, and different sensibilities for quality and safety mean that we have a high degree of variation in our workforce. So the result is that stuff can get missed. Wrong site surgery, med rec, care transition issues. And we see these things going wrong, but if we're not trained to know how to fix it, it just keeps happening. It's super annoying, it's super frustrating, and I believe it's one of the main contributing factors to the burnout that we experience in healthcare. We see the same pens rolling off the desk all day, every day, and nobody seems to care because a lot of people aren't sure what to do about it anyway. In healthcare, it is our highest ambition to reduce variability in healthcare delivery. So we have to do that for our own work. And even though this is a second profession for everyone, most everyone who is in it, it's a unique profession. It's a unique discipline, and it needs a training pathway and a body of knowledge too. Because if there's no best practice, no standard or measure, how are we going to know if we're improving our own selves and our own contributions? How can we improve? So herein lies the problem. The focus has been on what needs to change in healthcare. One more rule, one more reg, one more standard, one more ambition. That will make it all better, right? Wrong. Definitely wrong. We've had too little focus on how to achieve these goals. We haven't talked enough about who should be doing what work at what level and what skills and behaviors and competencies must be present to meet these demands for all of the improved outcomes that we want to see for our patients. So here's the pencil sharpening part. We got to fix this. So NACU set out on a journey, and our goal was to retrospectively redesign quality and safety from the outside in. And what we did was develop a healthcare quality competency framework that has 8 domains, 29 competencies, and 486 skills, which we stratified against foundational, proficient, and advanced levels. Now, when I say 486 skills, people, I gotta like block the exits, right? If you're like, I don't wanna do 486 of any of those things, right? So it's okay, because this framework was designed to support the entire quality infrastructure, with individual contributors supporting it in pieces and parts to create the whole. So not only did we create this standard, but we validated it twice in the market. First with those doing the work, and second with those leading the work that said, yes, that's what I want my people to be doing. And now we are creating a movement to align the profession and the discipline towards these standards. We set the standard for individual clinical contributions and for teams so that you could do your best work, because we know physicians, nurses, quality support teams, care coordinators, risk, infection control, the Q is all of you. So where you work, there are 5 generations of individual contributors who have either been trained, or some maybe even not trained, on quality and safety. And so I think I pretty much litigated that, right? Like we're on the same page? Okay, got it. But any quality person worth their salt is gonna want data to prove it. So fine. We'll create an assessment, and we'll get in there and we'll understand what the market is doing, so we can understand where we are today and get a plan to go forward together. NACU's research around this competency framework show us a few things. I have a few slides to share with you on the data. At the highest level, around the 8 domains of quality that NACU developed and validated, we see that the workforce writ large is focused largely on 3 things. They are working at the highest levels of the competency spectrum in these 3 areas: quality, leadership, and integration, regulatory and accreditation, and patient safety, which totally makes sense. Think about the past 25 years of healthcare, 1999 to Air is Human, right? Safety movement is born. We were focused on safety before, but we got a lot of momentum in 1999 and beyond for that. Also, lots of work around regulatory and accreditation, more rules, more standards, more guidelines. That will fix all of this, right? And so we've put a lot of attention on this. These are the areas that the workforce writ large is performing at lower ends of the competency spectrum: population health and care transitions, health data analytics, which I know you here dive into that a lot, performance and process improvement, and quality review and accountability. Quality review and accountability, your president just mentioned y'all are interested in advancing payment models. That's kind of what this is. This is measures, practitioner feedback loops, and payment models. So the things that are going to require us to, we need to have in order to advance healthcare quality and safety and meet all the ambitions we have, are the things that we're actually performing the lowest on as an industry. Next level of data. So we can take this national data set and drill it down by systems, regions, sites, and all the way to individual contributors, which I'll show you in just a minute. So here's an interesting data point. So here we looked at the example domain of performance and process improvement. That's one of the 8 domains that we have. And the competencies in that domain are implement standards to improve processes and PPI, use change management, and apply project management methods. So let me just help you out with a key real quick to make it easy, and then I'll summarize what the data says. So blue is advanced, green is proficient, yellow is foundational, and gray means that the respondents who said they work in that area didn't identify with any of the skills or behaviors that we laid out. Okay, vacant. So we take the national data set, we drill it down, we're in a system, we have 3 hospitals we're looking at. The leader of the hospital says to, we say, how do you think you're doing? They say, well, we feel like hospital 1's doing pretty good. Hospital 3 is a star. And hospital 2, we have some pretty serious concerns. So we show them the data. And there it is. We can see it too. We don't just have to think it anymore. We can prove it out. We can see that in hospital 1, across all 3 categories, they're pretty well distributed and strong at the proficient and advanced levels of the competency framework in PPI. We can see that hospital 3's got a lot of blue, and they're operating at more advanced levels. And we can see that hospital 2's got quite a bit of gray. They have people working in roles, and they don't do any of the things that we have validated and said they should be doing in the national standard. So this is my favorite visual that we have of our work, and this visual represents a single system, single region, with people in the same role, same job title. Each bar represents a person. So the height of the stack is their cumulative level of contribution in relationship to the competency framework, and the color represents what they do at the highest level. And what you can see here is we have a highly variable workforce. The levels are different, the types of work are different, but they have one goal and one agenda, and so they gotta level this back out. So what we help them do is take all of this data, their larger data sets, hospital data sets, individual data sets, and then we help them target set. We say, well, what do you want your workforce to look like? How do you want them set up and situated? And after we define that, we help the leaders and each individual get there. Multi-month, multi-year commitment to workforce alignment, workforce development, so that we can meet this mission. So I don't know about you, but I'm pretty tired of hearing about reports from the OIG and others that continue to confirm that Medicare beneficiaries, 25% of patients will be harmed as a result of receiving medical care. That proves out in other papers outside of the Medicare population, by the way. And I'm frustrated that 43% of the harm that is experienced in healthcare is identified as preventable. And I'm really done hearing about our broken financial healthcare system, our broken finances in our healthcare system. It's exhausting. We know that 25% of all spending in healthcare is waste. So I think most of these problems are driven by variation. Not only variation in care, which you all are focused intently on, but variation in our skills. And the one thing that we haven't focused on as an industry writ large is the workforce, which, by the way, is the single largest expenditure in any healthcare organization. So at NACU, we're wondering, maybe, just maybe, if we focused on us, if we focused on the team, if we were committed to moving the workforce forward, we could reduce adverse events. We could reduce waste. And we could bend the curve on the heartbreak that is experienced by families and friends who experience medical error. So any new way to work is going to require us to do things differently. And it's going to take time. And it's going to take resources and an unwavering commitment to quality and safety. And I believe it's going to take transformational leadership. So the elements of transformational leadership are listed here. You need and there are many different versions of this, but to simplify, clear vision. What are we trying to accomplish? Rally cry, align the team, charge the hill. Strong relationships, and the ability to celebrate shared success. The good news is this is entirely doable, and organizations all over the country are actually doing this. They are actually transforming their workforce. They are resetting and rebranding quality and taking this whole operation to the next level intentionally. So I work with a lot of health systems in the US, and recently I've been able to work with the largest health system in the US, the Veterans Health Administration. The VHA has had its fair share of quality issues, we're clear on that. But the VHA today is using transformational leadership strategies to reset, rebrand, and reboot quality in their organization. Under the leadership of Christine Groves, they are reimagining quality systems, process structure, and workforce competencies. And I'll tell you what, if the VHA can do it, anybody can do it. The VHA has a clear vision to make veterans care the best care. The VHA has a rally cry. It's the NAECU framework, it's the wheel. For them, the wheel represents the way. And it has become the center of gravity at this organization. They don't have a meeting or talk about advancing quality and safety objectives without having the wheel physically present and referenced multiple times throughout the meeting. Not only that, but we've partnered up with them and we've given them a NAECU navigator. That's like a coach, a professional trainer who locks arms with you that says, we're going to get you from here to there. VHA is developing strong teams with strong relationships. They're empowering their staff to spread this across all VHA visions. VHA has literally hooked their wagon to the NAECU train for quality and safety competencies, and they're reimagining how to pull this through their entire workforce. They're celebrating their success, and they're participating in communities of practice to improve veterans' care and to improve the effectiveness and the engagement of their team. Christine even told me that someone she didn't even know reached out to her from one of the regions and said, I wasn't sure that the VHA cared much about quality. And I didn't know if they cared about me. But now that you're working with NAECU and doing the wheel, I can see that you do care about quality, you do care about me, and I'm taking my resume off the market. I'm here to stay. Pretty impressive. So Robin Betts, she's the Vice President of Quality, Safety, and Regulatory Services at Kaiser's Foundation Hospitals and Health Plans in Northern California. And they are doing this too. They have assessed their team, they have organized their team, and now they are skilling their teams to do their very best work. KP is leveraging this methodology and using NAECU's framework to bring in the data about their own teams. And it prompted them to sort of take a deep dive, because one area for the national data set and also Robin's data set, which was true, is that ethics is an area that most people don't think about. And 42% of people who are working in quality, by the way, with our national data set, said that they do not do ethics. I don't even know exactly what that means. I think they might do it and not know. We got to peel back the onion on that. But Robin saw the same data and said, oh my gosh, maybe I ought to be having workshops and teaching my team about ethics, especially when you're dealing with data, right? So Robin has meetings with her team, an hour-long lunch and learns where they're unpacking content that we give to them to really teach their people about ethics. And not only that, but Robin's president of the Northern California region found out about this, and now at their executive team meetings once a month, they pause for ethical moments. And they talk about how they should approach things and what behaviors need to be present in order to proceed with the highest levels of integrity. KP has a clear vision to move from the compliance mindset, as Robin calls it, which she says, you do compliance, you get the C. They want the A. So they're moving to the excellence mindset. They have a rally cry. It is the NAECU framework. It's the wheel. The wheel represents the way. Kaiser is advancing time and building their relationships, and they're celebrating success. Earlier this summer, over a happenstance lunch I had with Robin at a conference just like this, she told me her team now pauses for what they call accelerator moments. That's how we kind of talk about the work that we do. It's a workforce accelerator. She's like, we do accelerator moments where we stop and we learn and we share so that we can all grow together. My last example is Augusta Health. So Augusta Health is a smaller organization. It's located in Fishersville, Virginia, and they are making their way to excellence as well. So their leader there is Chief Medical Officer, Dr. Mufaz Haq, and Laurel Malloy is the Administrative Director of Quality and Safety. So those two people have teamed up because they wanted to create a standard process for their quality infrastructure. They have goals to improve data governance, establish more robust improvement tools and methodologies, and to expand their impact in population health. Not only that, but Dr. Haq wants to take this content and put it into his residency program. What could happen if we moved upstream and started teaching all healthcare contributors the same vocabulary, the same toolkits, the same skills, the same behaviors, the same competencies? Dr. Haq is setting an amazing example in this space, and there's a lot of nursing programs that are too, by the way. George Washington University, Western Governors University, they're locking in and docking in to this competency framework. So Dr. Haq and Laurel, they have a clear vision. They're aligning their team, and they're even pulling in their service line leaders on this and making sure that they have a pathway to pull it through the organization. HR, they're involved too. They're planning to incorporate all of this and engage across the organization. And they're using the rally cry too. The wheel is the way. And they are building relationships cross-functionally and establish a new management team that is really advancing all of this. So, by improving us as individuals and as teams, we really have a good chance at impacting the outcomes that we want to see. We can deliver higher quality healthcare that is absolutely safer. And we can support the workforce. We can make sure they have the skills that they need. We can make sure there's talent development plans, career pathing, succession planning. And I believe that we can reduce burnout in the process and bring joy back to work. Because when we focus on the Q, we're focusing on all of you. So, quality is impacting lives. And it gives life. It even gave me mine. It's because of quality improvement that this beautiful person, my grandparents' little girl, and my mom survived to have kids and to have grandkids. So I never expected this to happen, but this is actually a full circle moment for me. I'm literally here advancing quality and safety because at the point in time when my grandparents needed cardiac surgery for her little girl, it was high quality and safe. So the Q is me too. Thanks, everybody.